We're going to go ahead and get started. We know that people will be joining as we continue, starting with the introduction, which I have the pleasure of giving to you. Welcome. I'm Marianne Faison, the Executive Director of the Dallas-Fort Worth Business Group on Health. And with me is Chris Spisak, who is the Executive Director of the Houston Business Group on Health. We are co-hosting Houston Business Group and Dallas-Fort Worth Business Group on Health, are co-hosting today's webinar. In fact, we're actually co-hosting the Employer Oncology Management Learning Collaborative is what this is all about. In Houston, May 7th, Chris hosted an in-person introduction to the Oncology Management Learning Collaborative and the new Learning Collaborative Oncology Management Guide. And we did the same in the Dallas-Fort Worth area on May 8th. To have our first in-person presentation and discussion with our wonderful speaker today is Karen Van Khalil. She's leads the Florida Coalition, and she and her another coalition leader, Cheryl Larson from the Midwest Business Group on Health up in Chicago, designed together with their employer members this wonderful oncology management guide. That we're sharing with you. We shared it on May 7th and 8th in Houston and in Dallas, and we're continuing on because it's such a comprehensive learning tool for managing your oncology cases. So we're going to continue today with, there are 7 parts to the coalition, to the Oncology Management Guide, and Karen will go into all of that, but I have a couple of preliminary announcements I'd like to get through quickly. So next slide. Diane, if you can move that. So here's the title. On August 21st, just to let you know, the Dallas-Fort Worth Business Group on Health will be hosting an in-person general membership luncheon, and the topic will be Cell and Gene Therapy Strategies, Precision Medicine Solutions. And that would be during the lunch hour. And then September 17th, if you'll mark your calendars, we're hosting an afternoon seminar on the Power of Well-Being Fall Symposium, Mind, Body, and Purpose. That's an all-afternoon symposium, which we've done several years before this on different topics, and this year it's on the Well-Being Fall Symposium. Mark your calendars. It's all complimentary to employers, so keep that in mind when you're thinking about registering as well. And then the Texas Business Group on Health and Dallas-Fort Worth Business Group on Health will be hosting its 21st Annual Benefits Forum on December 17th. And each year we come up with a different type of different theme. And this year it's Wicked Benefits. Last year we were doing a disco. Year before that, I think we did Maverick or Yellowstone, and other times we've done Maverick and I think that, anyway, we've always had a good theme. So this one is Wicked Benefits, dress occasionally for this, and that mark your calendars for December 17th. It's an all-day event at the Irving Convention Center. And of course, you will want to wear the proper attire for Wicked Benefits. So the next slide. This today's program webinar is approved for 1.5 hours of HRCI and SHRM continuing education credits, and these are the numbers. If you need them later, if you didn't write it down this time, we'll give you a copy of the slides that you can refer to. And a big thank you to Genentech as our primary sponsor and Merck and Pfizer as other 2 sponsors for this oncology management series that we're presenting, the on-site programs that we had May 7th and 8th, and now today's webinar number 1, and then there'll be a second webinar on July 24th. And to follow up with the Oncology Management Guide. Any other slides, preliminary slides, Diana?
No, Chris can now
okay.
jump on and announce his
okay.
announcements.
We'll launch right into the discussion with Karen Van Khalil. She knows what she's talking about, and this oncology guide is going to be one of the most important resources that you'll have for managing high-cost claims, and oncology being one of the highest cost claims that you all are managing. So you should be able to come away with some pretty useful information for managers your high-cost oncology claims more effectively. So with that, let me turn it over to Karen Van Khalil, and welcome back. online virtually today instead of in Dallas itself or in Houston. So,
Okay, Chris, I think you were going to jump in here. Did you have
Just
any?
go ahead. Just go
Yeah,
ahead.
go
We
ahead. Okay.
kind of lost
I,
order there. That's all right.
oh,
yeah. Can you hear me okay, Marianne? It was a little bit hard to hear you, so I'm not sure whether
oh,
that's the
okay.
whole webinar or can you hear me all right?
Okay,
Okay, I see a
no
yes.
audio.
I know I'm from New York. I'm loud. People usually can hear me all right. So, anyway, thanks so much for having me back. And as Marianne mentioned, we developed what we call an employer guide and insights for oncology management. It went live last June, and we did the work with the Midwest Business Group on Health. And Chris, I'm going to use your word that you said early on after you saw this, and that was, you asked if we were going to try to keep this evergreen and keep it updated and continue to work on it. And the answer is yes. I am seeking funding to be able to really expand it and to disseminate it, but we really appreciate so much these types of events because we can also surface other employer insights. We really appreciate good case studies, but even just sharing, what's worked, what's not, and lessons learned. So a little bit harder in a virtual setting, but at any time, please, jump in on the chat. I know Diana's going to be keeping an eye out. It's not, a huge group, so you can raise your hand, jump in. So one of the things that I was asked when we were doing the in-person meetings last month was, could you talk about why? Why did you do this project? When I came to the Florida Alliance for Healthcare Value in 2011, already cancer was the largest spend for our employers in Florida. And I know that the business group on health a couple years ago said, and now cancer is the number one top spend for employers in the US. And I think that Florida probably got ahead of everybody else because we had really high prevalence and we also have really high costs. So, Florida, unfortunately, is the number one most expensive state for employers purchasing hospital services. That's been the case for a while. So I think that fueled it for us. But aside from cost, our employer members were saying, wow, this is really overwhelming for us and for our plan members to navigate cancer care. And cancer care is so complex. It's hundreds of different conditions. It's not just one thing, and it varies so much from cancer type to cancer type, and then all the stages within each. And help us to understand better what's going on with innovation in diagnostic testing and with treatments. A lot of them have very hefty price tags. So how are we going to do this? We also saw in Florida a lot of variation in what kind of care was being given, depending, market by market, provider by provider, as far as adhering to standards of care. And another thing that we talk about a lot with high cost claims, and I know you all probably have too, is there's a lot of billing errors, and we really saw a lot of that in the oncology space. I already mentioned about navigation and how challenging it is, and how overwhelming. You all know how fragmented and siloed the healthcare system is, but we saw with oncology that when you're talking about you know, traditional retail pharmacy, specialty pharmacy, mail order pharmacy, they weren't talking to each other. And there was a lot of waste and a lot of confusion. Sometimes a treatment doesn't work out of the gate. And then if you've got 3 or 4 months of mail order, sitting there, and after, a week, it's been canceled as the treatment, that's a big waste. So lots of problems there. And then we'll talk about some of the things that drive treatment delays and misdiagnosis that employers could focus on. Next slide. Also in the why, and the first slide there was what did they share with us were the problems that they were having, the employers. This was us turning around and saying, and also, did you know that 1 in 3 cancer patients enter bankruptcy, which is really a staggering statistic. One of the things we talked about a lot, and I didn't put a percentage on here, it just says high percentage of patients initially misdiagnosed. There's a pretty decent body of literature that says that there's a good chunk of folks who are being initially misdiagnosed, and we're going to talk about biomarker testing today, but also kind of mixed in the data is people who are not put on what would be considered the best practice course of treatment. So there's a good number of folks who are not getting the right diagnosis and maybe not the right treatment plan. Sadly, a lot of the patients, even if they're available to them, do not seek second opinions. And reasons given have been, oh, it's going to cost even more money. I'm good with this diagnosis. Or, oh, I don't want to wait. Who am I going to go see? I don't want to delay. I have cancer. I need to get treated. And then there were some people who said, I don't want to hurt the feelings of my oncologist because this is the person who has, is going to save my life. So a lot of barriers to get over on second opinions, and second opinions are really important in confirming that diagnosis and that treatment plan. Sure, you all know a lot of money is spent in the last 2 weeks of life for a cancer patient. So we'll talk a bit about palliative care and hospice care, social determinants of health, but also other social risk factors that prevent employees from accessing care. We'll talk about that. One of the things that we shared back, because we had done a research study pre-COVID with 7 of our employer members in the greater Orlando area. We had probably about 7,000 cancer patients in that database. Not one single one had one single claim for mental health support. And we couldn't believe it. Our medical director couldn't believe it. And we were trying to figure out why that would be the case, because certainly there's an enormous amount of anxiety and stress and depression that needs to be dealt with, during the cancer journey. I think you've heard this before, and as employers, you're probably plagued with this, that employees do not understand their benefits, no matter how hard you try to educate them. And when it comes to cancer benefits, if they don't have cancer at the time you're sharing information, they probably are not remembering that. So, kind of a now more than ever, they need to be able to understand their benefits when faced with a cancer diagnosis. And the other thing that we shared back was in talking to employees, there's still a lot of concern about sharing their diagnosis with their employer because they're afraid they might lose their job, and really appreciate having confidential, anonymous support. So these were the big whys on why we needed to move forward on this. And another why was that there were a lot of really great toolkits and checklists and such that had been put together over the last handful of years. NCCN, both MBGH and Flora Alliance were actively involved with an employer group that created toolkit, National Alliance of Healthcare Purchaser Coalitions that we're all members of, did a lot of work in oncology. They did a deep dive, they did modules, they did checklists, and we were involved with that. Community Oncology Alliance created the National Cancer Treatment Alliance, and they focused on biomarker testing. And what we heard back from the employers was, wow, where do we go for what? So we wanted to make sure that we pulled in to our employer guide all that great work, plus some other things that we came across that would be useful. And I'll talk about the layout in a second, but this slide that you're looking at is the first page of what we call the placemat. And I think Diana was going to drop it in the chat. She probably has already. So you can go ahead and download that, and it's two-sided. I'll do the next side in a moment. Oh, there it is. Okay, I see it now. So and this basically covers some of these top drivers of cost that I've already talked about. But what I want to point out is that we really accessed the employers in our two coalitions to help us to develop this. And you can see down on the bottom left, I won't read all the names of the folks out, but between the two coalitions, we had a good number of advisors, if you will, and they shared their challenges, their stories, their insights, and that's captured in this employer guide and insights, as well as the larger group. We involved all of our employer members for both of the two coalitions in doing webinars like this and stopping and asking certain questions once we did a little bit of education. And so those employer polls are in this as well. And all of this is housed in a microsite, in a website. So before we go to the next page, same sponsors that Marianne mentioned. So our initial sponsors were Genentech, Merck, and Pfizer. And for ongoing support, Merck, we appreciate is continuing that support. So let's go on to the second page. This shows you the content areas, and there's also a QR code in that yellowy orange box. You could click that to get to the microsite. And the way it is laid out is these 7 content areas. And I want to point out that that's not linear. I said that at the in-person events, but for those of you who are not at either of those, because you certainly start paying for care, which is over in position 7, right out of the gate, and survivorship should be addressed right up at the front. So these are just content areas. We have in this microsite a really, really good glossary too, because we found that the employers didn't understand some of the language associated with cancer diagnosis and treatment. Our employer members are not healthcare businesses. These are not clinical folks. So we keep that up to date. And what you can do is you go in to that section. If you only want to work on prevention, go in that way. And that's why we organized it, because some of these other toolkits and checklists, it was just everything kind of, laid out there. So when we had the in-person meetings, we covered cancer prevention, screening, and how important early identification of cancer and that diagnosis is. And we had really, really good conversations. We tried to get through everything, but didn't. And so that's why I was asked today to talk about treatment and to talk about navigating care and care management. And then that July date that Marianne mentioned, we'll talk about survivorship and return to work and paying for care. So when we talked about, why don't we go ahead and go to the next slide, please. So in the in-person events, just some of the top level, things that we talked about. Screening rates are very, very low, and how important it is to improve screening rates. And so there was a lot of conversation about what strategies that the employers were deploying to be able to get those rates up. And also talked about vaccines, which was a surprise to some of the employer members. I don't really think of that as part of a cancer strategy, but the HPV vaccine helps prevent certainly most cervical cancers, which you probably already know, but several other kinds of cancers. So we talked about that in men and women. And then the Hep B vaccine, can help lower liver cancer risks. So this was, some new information to some people. But then we also talked about, prevention and, healthy weight, obesity, overweight, A lot of employers have an obesity management strategy, and we talked about how that is also a cancer management strategy, because there are probably 30 cancers where obesity is a risk factor for them. So we spent some good time talking about that, and the MBGH coalition has done a really good body of work around obesity, and so that toolkit is in the employer guide, for example. Certainly talked about tobacco cessation. I know for us in Florida, we still have a lot of folks who still smoke. And when we were doing the different employer groups over time, just the different strategies that folks were undertaking to be able to get folks to quit, to support them in that process. And then for us in Florida, and probably also for you in Texas, protecting your skin can prevent skin cancer. So these are some of the things we talked about in the in-person events. Let's do the next slide, please. And as I said, early identification of cancer, that's to me, like the number one thing, because we really are seeing a lot of late stage cancer diagnosed. And the later a person is diagnosed with cancer, the worse their chance of survival is. And it also relates to more complex treatment and maybe, additional problems that are associated with treatment, and that results in a higher cost of care. So we want folks to survive cancer, and employers also, want to be able to better manage costs. So we talked about how important that is. So screening is really key. But we were finding that most of the employers have, pretty low screening rates where screening tests are available. And there's information in the employer guide that you can look at to see what some of the employers have done to get those rates up. It's also important to note, though, that only 14% of cancers are diagnosed through a preventive screening. And not all cancers actually even have a screening test. So only about 30% of cancers do. So we talked about other ways to be able to diagnose cancer early on. And advanced primary care, and I think the Houston group has focused on this. Chris, I think that's correct, right? Or you're going to be
That is
working.
correct. And we're
Yeah.
actually hosting a forum on said same on June 26th in Houston.
Coming right up. Okay.
Yeah.
So advanced primary care would really give the patient and the provider a good opportunity, especially at that first visit, which could be like an hour and a half or so, an hour plus in time of assessing, what's going on with you. And there might be signs and symptoms of cancers that you wouldn't pick up on screening, but also to catch people up on screening as well. So we talked about thinking about your primary care strategy also as a cancer management strategy as well. I see a note asking if it's recorded. It's recording right now, and I know they're going to share that with you all. So we also talked about the multi-cancer early detection tests, which are not FDA approved yet, but they certainly have entered the market, been around for a few years, and they can catch cancers early, $900 to $1,000. So we have some information in the employer guide about that. But again, we talked about that at our meetings. Next slide, please. So to jump into today's topics, navigation, care management, and also treatment. Next slide. So first, I'm going to do navigation and care management. And there is some nuance to the two terms, or at least as we progressed through this learning collaborative, we looked at a distinction. They each play a really important role, and there is some overlap, but there are some important differences. Next slide, please. So care managers, and first let me just shout out to Marine Max. That's actually one of our members, and there's a really good case study in the employer guide. They have gone all in with care management and using a nurse model. And so we had a lot of really good discussion about what the care manager does. And we've talked about how challenging it is to navigate through, and talked also about how siloed everything is. And we've talked about how, challenging it is from a financial standpoint and psychosocial and mental health. Well, the care managers really are there for the patient side by side to assess all of those needs and to help manage getting the right diagnosis, the right treatment plan, any wraparound services that are needed. And, but they also, some of them do help on the navigation side, more of the social service side, and advocate. So I'm not going to get into the whole Marine Max story because that would take, the entire rest of the time, but please look for that. They've really had impressive results in terms of how much they've been able to help folks and in terms of outcomes, but also in managing costs. Navigators are next up. So again, a little bit of a nuance. I mean, they're still very patient-centered and side by side with the cancer patient, but they tend to be social workers or trained to do like case management, but they do understand cancer care and how complex it is. And a lot of barriers exist, we learned, with folks being able to access care in a timely manner. Certainly out-of-pocket cost, but also challenges. It could be the dependent on the plan. Could be, obviously the plan member themselves. So it's the family unit has some challenges with childcare. Some workers don't have transportation, or perhaps they're getting care for a rare cancer that involves, going a distance. Paying things like utility bills, paying mortgages, paying for food have come up as, hey, I need to pay for my care. How am I going to pay for everything else? There's always challenges with insurance, no matter how hard you all try to streamline it, and navigators help with that and advocate and help move things along paperwork-wise. And we'll talk about prior auth as an example. Cancer navigators also can help that patient or that family member understand what's covered and what's not, and help them to plan financially and figure out if there are payment plan options and finding ways to, lower treatment costs. Maybe it's a site of care strategy and they could get redirected to that. So care managers, really sort of the very clinically focused. Navigators tend to be financial and social needs. Next slide is to ask you a question. So for those of you who are on the call, does your plan include cancer navigation and/or care management? And if it does, do you know whether the programs are well utilized? And if you could respond in the chat, or if you want to, raise your hand, we can. Let me see. I'm going to open up the chat so I can pull that off to the side and look at it. No. Okay. I don't know that that's a no to offering, I assume. Some of the health plans have like a chronic disease management and say that oncology can get tucked in there, but typically those folks haven't had the level of expertise. Okay, good. So we have case management, not specific to cancer, looking at it. Okay, great. One of the challenges that we saw was that we had employers who were paying for oncology nurse management. They were paying for navigation, but people weren't using it. They didn't know it existed. They didn't know how to connect. And in one case, which is what tipped off our doing a cancer navigation program, was the claims process that was the trigger mechanism. So it was like 3 months after the cancer diagnosis that that patient was getting a call to say, "Hi, we're here to help." And the person had already, had surgery, that had chemo, that had radiation, and it was really too late. If they even picked up the phone because it had the health plan name and they thought maybe they were getting called about bills that needed to be paid. So we knew we needed to figure out a better way for folks to get connected to all of the benefits, including care management. So thanks for the folks who did respond. Great. I'm glad that some of you are considering and offering it now. So let me just talk for a few minutes about a cancer navigation pilot program that we did. We do demonstration projects. We're a 501c3 research and education organization. And literally the first day on the job, I had my board chair, who was with Orange County Public Schools, ask me to come to a meeting with their health plan, with their carrier, because they had so many cancer patients and nobody accessing the oncology nurse management program, which was very, very expensive. So it was a PMPM, and they weren't getting the connection. And it was that 3 month, couple month lag time. So it was like in a whole year, maybe 40 people were accessing it, but kind of late in care. And so we were brainstorming around how could we close that gap. The health plan said, "Oh, well, the data system, it's going to take 2 years for us to figure out some kind of, information system change." So we created a very simple program. She had an extra position in her benefits department. She hired a nurse who had care management and case management background, and we had flyers everywhere that said, "If you or a loved one have been diagnosed with cancer, call this number to learn your benefits." And so they called this lady, Katie, and the first day she had 181 people call. So there was a lot of pent up demand. And she hundreds of people called as you would imagine over time as they learned about it, and she was able to do a warm handoff to the oncology nurse management program and to other services, and she learned a lot about the social needs. So it was really eye-opening how much need there was for a connector. Well, we knew we couldn't scale it. Not every employer would be able to, have somebody in their benefits office. But Orange County Public Schools is big, 35,000 covered lives, so a good sized company. We also talked to Disney because they had the on-site health center in the Epcot parking lot. It's called the Center for Living Well. And they said, what about a warm handoff for our folks who get their primary care to connect them? So we came up with a program with the two different models. One was a marketing campaign and one was a warm handoff from primary care. And what we wanted to do was get the employees to understand their benefits and also to reduce financial and emotional stress. Hopefully it would help with productivity and certainly improve access and adherence to care. So we did this pilot for a year or so to kind of see what would happen. Next slide. So you can see here down at the bottom, if it's a white bar, it's no, blue is yes a little, and green is yes a lot. Did your access to this navigator who we hired, and that was with the Patient Advocate Foundation, help you to resolve your issues and address concerns? And you could see 71% said, yes, a lot. So let me back up a little bit. What I meant to say was what we did was we loaded up to the PAF navigators all of the benefit information that each of those employers had and got them to understand that, so that when that person called or the warm handoff, they knew what the benefits were for those two respective employers, and then they could really hit the ground running and explain to the employee what was going on. So it improved access and adherence to care and to the treatment plan. To some extent, it helped minimize time away from work. It certainly helped them feel like their employer cared about them and reduced stress. So we were really pleased with those results. Next slide, please. There were also some measures that PAF had. There's like a stress, distress scale that they used, and we had 77% of the participants had a pretty big reduction in their level of distress because of the help. It was asked, because we've helped you out, are you feeling less stressed out? We also had a pretty big jump in how much they understood their benefits and their healthcare plan entirely. So that was really helpful for them in the go forward as well. And then one of the things that we saw was a great need was employees were kind of intimidated by talking to their providers and asking questions. And the navigator helped them and gave them tools. And I will, when we get to a slide, a couple down from now, I'll explain some of the tools that were given to them to help them increase their confidence in advocating for themselves or their loved one. Next slide, please. Okay, so everybody was really reporting really high levels of satisfaction with the program. Sorry, if you could go back. 95% increased their understanding of the plan to some amount. It helped them. 100% of them said, I'm really getting value out of the plan. I understand it. I know who's in network. I know who's not. And also, local community resources that could help with food, with transportation, with childcare, or the employer learning of these challenges created a separate fund where they could access that. So we were really pleased with the satisfaction of the program. Next slide, please. So one of the things that we gave every single person who accessed our cancer navigation program was the appropriate NCCN guideline for patients for the cancer that they had. And I think, Marianne, you were going to show a version of it I don't know if you're still going to do that, but here are some of the different covers of some of these guides. I have said this, and I'm going to apologize if you've heard me say it every single time, but if you take nothing else away from this presentation, know about these NCCN patient guides. They are updated regularly. They have hundreds of them for the different cancers. You can download them for free. It's in the microsite, in the employer guide. You're going to get these slides. That link is right there. Or you can buy an actual physical copy off of Amazon. I got on last night and I saw some are $10, some are 12, some are 15 or 16. They are worth every penny. They are so clearly written in terms of each of these cancers. What kind of tests can you expect? What kinds of questions should you ask your provider? What does treatment look like? They are so wonderful. And I think I saw that Sam was on. Sam, are you still on from NCCN?
Yeah, I'm here. Can you hear me?
I can. Have I left anything out about your wonderful patient guides that you want to?
I don't think so. Yeah, I was gonna throw a link in the chat, but it looks like you already got it covered. So
Yeah,
yeah,
go ahead, put it in the chat too. They
awesome.
can't
Yeah,
click
will
on the
do.
slides, so go ahead and do that.
Awesome.
I'm like, the biggest cheerleader, I think, for these patient guides. I was after church on Sunday, a friend of mine who's just been through uterine cancer. I had given her the book, and she was telling somebody else, because she's done with all her treatment now, rang the bell, the whole thing. And she said, talk to Karen, because she knew about these patient guides, and I don't know what I would have done without that. And she was talking to somebody who had just found out that they have esophageal cancer. So patients are really appreciating them. So this is an example of a resource. We've got lots of resources in the employer guide, but wanted to highlight that one. Next slide, please. Okay, let me just do a time check. Okay. Thanks, Sam, for putting that in the chat. So, we have I don't know, what is it, the 5 rights, the right care at the right time, at the right price for the right patient of the right quality, whatever. I probably left them out. You're welcome, Sam. One of the things that we spent a lot of time talking about is how to make sure that the patient is getting the right care. So, for the sort of the balance of the time that we have left, I want to talk about biomarker testing, artificial intelligence, and second opinion programs and how important they are. Next slide, please. So, Midwest Business Group on Health, I think it was in 2023, did an action brief. I think I have that right from a couple years ago. It's in the employer guide, and it is terrific. They really explain, and I'm going to grab it here so that I can speak to it. And this is about precision medicine. What we were hearing from the oncologists was how important it is to get employers to understand coverage of biomarker testing. There was a stat that 66% of oncology providers reported a lack of biomarker testing coverage as a barrier to patient access. Biomarkers are, as it says here, substances such as proteins and genes that are found in blood, body fluids, or in tissues. And by testing them, it can help really fine-tune the diagnosis of the type of cancer. And if you recall, I said we've got a lot of misdiagnosis. This is a way to ensure that the right diagnosis is happening. There's biomarker testing that's being developed all the time. They don't have it for everything yet, but more and more. It also helps with identifying the staging and finding the exact right treatment to ensure that the patients are getting the medications and the therapies that are most likely to work for them. And that biomarker test can also measure whether the treatment is working or whether the cancer is returning. And what the oncologists are saying is it allows us to practice precision medicine. So the action brief it's kind of long from MBGH. Let me take a quick peek here to see. I would say it's probably 9 pages, which is long for an action brief, but it really talks about how important it is to cover these and to check with your carrier to make sure. So let's go on to the next bunch of slides, because first we want to see whether you all are covering biomarker testing. So again, respond in the chat. And while you're doing that, I'm going to get organized with my notes for a second here. Is anybody covering? Do you know if you're covering biomarker testing? Okay, I don't know. Okay. All right. Well, we're going to keep going then. So we're going to give you a lot of employer action steps. So you're going to get the slides. These and more are in the employer guide. So questions to ask your carriers. Does your plan cover biomarker testing to determine a patient's potential clinical trial eligibility? Was one of the questions to ask. If there aren't in-network providers or labs that can perform a specific biometric test, does your plan waive the out-of-network financial penalty to the member? And does your plan cover biomarker not just for diagnosis and treatment, but for that ongoing monitoring and management? And what are the rates of, if there's prior auth for biomarker testing? What are the rates and the appeals and such? And this came about, Sandra Morris is a nurse. She was the benefits person for, I think, Procter & Gamble. She's on the Midwest Business Group on Health board. She was our expert with her nursing background. And she said, it's an oncologist who's ordering the biomarker testing, and they are not going to order testing that isn't necessary for them to be precise. And that really the feeling is that these prior auths are barriers when it comes to oncology treatment. So she said, this is why you need to ask your carrier about the rate of approval on the initial and the appealed requests. And you're probably going to find that the rate of approval is going to be very high. So the recommendation would be, if you're seeing this approved and it's just a time delay and it's approved every time, remove that prior authorization. It feels like an extreme measure, but she felt very passionately about that based on what she had seen over time. Regarding the, out of network, her suggestion is don't charge a penalty if the lab that has to perform that specific biomarker test is not in network. If you do, you're probably imposing a financial barrier for that patient. And then she really did stress how important it is when you're asking questions about the biomarker testing that maintenance, that ongoing monitoring is important to cover as well. Next slide, please. More action steps. So, for those of you who don't know, you can use these, questions to go back. And again, they're in the microsite as well. But confirm with the carriers that if they do say that they are covering biomarker testing for you, that they have processes in place that are really staying on top of all of these new tests that are being developed, and that they're doing it for diagnosis, treatment, and ongoing monitoring. And, that they are also looking at where these labs are and get them in network. And the other thing that, to carry it all the way through, sometimes those call center representatives don't have the latest information. And so when they get that call, they don't know for sure whether it's covered or not. So there's a lot that the carriers need to do. We're trying to do that collectively with our employer members and the different plans in Florida. Next slide, please. So some of the carriers are not covering it. And what we heard back was that they would be considered experimental and investigational. So, which isn't necessarily true. But if that's the case for a particular test, does your plan have a strategy in place, so that an appeal can be filed and that it doesn't take a long time and that you have the appropriate clinical experts involved in the appeal? There was also conversation about some who have a narrow network that they have in place for biomarker testing. So next slide, please. We also saw a lot of really outdated plan language, and the language in the plans need to be modified to assure coverage, for appropriate use. And you'll see the specifics in the guide, but it really needs to have specifics about the requirements for genetic testing, for biomarker testing, and then also specific to diagnosis, treatment, and post-treatment. And I know this is just a lot all at once. And but again, look at this biomarker testing action brief. It lays it out. We have it in the guide. It is really, really important that this be covered because you want people to be getting the right care. The cost is several $100s, could be $1,000 or $2,000, but in the scheme of the oncology treatment cost overall, it is a relatively small percentage. And going back to that study that I talked about where we didn't see any mental health or behavioral health services, another thing that we saw in this few years of data that we were looking at, we saw an awful lot of starting and stopping of treatment. So the first one wasn't working. All right, let's try something else. This hit or miss approach is very dangerous and very costly because that individual survival is at risk, but you're also paying and you're paying again, and maybe eventually you're going to be paying for care that is the correct care. Next slide, please. So another thing that came up as a recommendation was to consider doing a member communication campaign to educate about biomarker testing. Again, timing is everything. It may not be at the time when somebody, needs that information. But if you have a cancer education webpage, that's something to consider. Confirm that all the tests that are FDA approved as companion diagnostics to match patients to all the FDA approved targeted therapies and immunotherapies. So I'm going to get into the therapies next. We saw disconnect between the tests being approved and the therapies not, or vice versa. So some of the these cell and gene therapies require a certain amount of biomarker testing. So make sure they're in sync. So we can go on to the next slide, please. All right. So we talked a little bit about artificial intelligence, and people got kind of, nervous about that, and I think you all know that folks worry about the inappropriate use of AI. But we really wanted to acknowledge that for over 20 years, AI has been used to analyze mammograms, and now it's been expanded to a lot of these really sort of tough cancers that are hard to recognize, like pancreatic, prostate, lung, and skin cancer. And not to disregard human expertise, but the physicians are saying this helps us make decisions about diagnosis and treatment. New standards, new treatments, new therapies, new drugs are coming all the time. It's very, very hard for everybody to stay on top of that. So, we're going to talk about paying for care in the next section, so I'm not going to get in too much into that today, but I do want to point out that we will be talking about how some of this is now shifting to outcome-based payment as opposed to, payment per use, because there's a feeling that it was like really driving up use. So we'll talk about that more in paying for care on the next session. Next slide, please. So wondering, do you know if your plan covers the use of AI in diagnosis and treatment of cancer? So you can answer in the chat. Again, I'm going to click on that, see. Got any responses yet on that? Maybe folks don't know, not sure. Okay. All right. Thanks. Okay. So it looks like an area to check in on. Next slide, please. So yeah, I didn't add a slide, but we'll have in the employer guide some specifics on questions that you'd go back to the plan on. Expert second opinion programs is another way to get the right the right care. And, I already mentioned a few times, there's pretty high rates of misdiagnosis or the incorrect treatment plan. And the real challenge is that the employers who are paying for and providing second opinion programs, the uptake is pretty low. But not all second opinion programs are equal. So we'll talk about that in a minute, but they're very helpful, in particular on complicated cancers, to be able to really zero in on what is needed in terms of advanced technologies and advanced treatments, and maybe also to connect people to clinical trials if there isn't a standard of care offered yet for that particular treatment. And the programs are provided by standalone vendors. Some of the medical plan carriers have them, so you can find them in a couple different settings. Next slide, please. So how do you know how to evaluate a second opinion program? And that was the thing that the employers said they needed help with. So if you already have a second opinion program or you're evaluating options, these are some of the questions to ask and some expectations. So how many people are actually engaging in the program? What are they doing to make sure that folks do gain access? But also, what percentage of the cases where second opinion was given resulted in a change in diagnosis or treatment? And learning about the criteria that were used to determine if it was a change. Sometimes it's such a little dosage difference that it isn't like, oh, this was the wrong treatment. It's just a little bit of a nuance. So it's really important to understand the magnitude of what determines whether it's a change in treatment or a change in diagnosis. For example, you want to know how easy is it for the member to use the program. One call does it all is what we said needs to happen. I mentioned, I think out of the gate when we started the webinar, that folks do not want to delay their care. That's a barrier to getting that second opinion. And just have one point of contact who they can work with to navigate through the process. If they have a navigation or a care manager, they can talk to that one point of contact and help them navigate. Something that was brought up by Sandra, the nurse I mentioned, she said, it's really important to go back to the member and back to the treating physician to say, this is why we made this recommendation, so that they understand, so that the physician understands for go forward, so the member understands what was different, not judgmental, but here's some new data, here's some new information, this is what we're recommending. Next slide, please. So lots of advances in cancer treatment all the time. Probably heard about stem cell transplants. It's, it says here, rapidly advancing technology. So it's removing stem cells from the patient or from somebody else to grow new cells and platelets to go back in to the patient. There is some risk involved with that. We have in the employer guide a lot of information about these different technologies, these different treatments. We need to keep updating it, but also going back to those patient guides, they really do explain these different technologies and treatments very, very well. Next slide, please. Immunotherapy. So using biologics to help the patient's immune system fight those cancer cells. So again, discussed in lots more detail in the employer guide, immune checkpoint inhibitors, CAR T-cell therapy, which I'm sure most of you have heard about, mostly because it was like the first big price tag immunotherapy that caught our attention, and all these other major categories here. Typically, immunotherapy is covered in the plans we found, but it is worth having a discussion with the carrier to see if there are any restrictions in place that might delay member access to treatments, like a prior authorization that gets approved every time. Eliminate it or streamline it. Next slide, please. So targeted cell and gene therapies. So again, I'm going to do a shout out to Midwest Business Group on Health because they do such good work with their action briefs. We were in Dallas last week at the National Alliance Strategic Leadership Summit, and we had an all coalition director meeting. And the MBGH folks said, hey, we just did an action brief on managing cell and gene therapies for high cost diseases, and hadn't seen it yet. We're absolutely going to include it in the employer guide. Again, kind of long. This one's 10 pages, but it talks about these high cost therapies and how many are out there, how many are on deck, how much they're costing, and what employers can do to be able to figure out how to pay for it predominantly. So again, on the paying for care in the next session, we'll really be looking at these cell and gene therapies, prior auth, step therapy, looking at stop loss insurance, shared risk pools. I know MBGH is working on a multi-employer risk pool. So site of care. So a lot of strategies that would be covered there. So this precision medicine, these cell and gene therapies, use the biomarker testing we just talked about to identify, within the cancer cells, targeted growth proteins and enzymes that can be destroyed through the use of small or large molecule drugs that are given to the patient. So it's very, very targeted. Next slide, please. So I didn't do a slide that says, are you covering it? Because mostly nobody is covering these cell and gene therapies because the price tag is so staggering. But if you are, ask, is it starting to be covered? What are you thinking about with it? Do you have prior auth? Are you requiring biomarker testing? And again, what are these rates again of the approval for it? So I think we're not as nearly as far along on the cell and gene therapy end of things with coverage as the biomarker testing. But to go back to what I said a few slides ago, you got to marry them up. If you're covering the testing for the therapy but not covering the therapy, look at that, and also read the action brief to see how you can pay for these really expensive treatments. Next slide, please. Clinical trials, lots of information in the employer guide about that, but there's great resources with the National Cancer Institute, or at least there were. So I have to go back and double check to see if they're still there. A reminder that the Affordable Care Act requires coverage of routine costs that your plan members, if they're in a clinical trial, we had to really do a lot of education on that with some of our employers who said nothing is covered if they're in a clinical trial because that's experimental, but had to direct them to what services they could be paying for. So I'll just kind of leave that there, and we'll go on to the next slide, which is onto the experimental care. So again, that would be something that's not received approval from the FDA for general use among the public. So there's a lot of experimental care for some of these patients who have very rare or complicated cancer that might give them some hope. And they've issued some draft guidance from the FDA on charging for experimental drugs, but it has not been finalized. I'm sure it has stalled. It was in the previous administration, but we're going to continue to track that. And certainly, if federal law is passed to require coverage, we will certainly alert. That would be a very big departure from the norm, but that came up during the process of our Oncology Learning Collaborative. Again, in the employer guide, more detail on that. So, getting towards the end here. So, since I'm talking about treatment and care, right out of the gate again, talked about how costs are so high in the last couple weeks of a cancer patient's life. And one of the insights that the employers shared, whether that was personally or through work, that many of them said was, I've never heard anybody say, oh my gosh, I'm so glad I put my loved one through all of this invasive and painful treatment in their last 2 weeks of life. And instead said, I wish I had known about palliative care and or hospice well before we accessed it. So a lot of really important discussions to explain the difference between palliative care and hospice. They are both comfort care and to reduce stress for the patient and the family. It is to alleviate pain related to the treatment and to the illness. On the palliative care side, typically paid by insurance or individually. It can be any stage of disease and can happen at the same time as they're still receiving treatment. So it is accompanying the treatment, and it typically happens in the hospital. Some confusion, folks think of palliative care as end of life, and it is not. Hospice services paid by Medicare, Medicaid, and insurance, there are different parameters depending on the plan, but the prognosis would be that the patient has only 6 months or maybe less of life ahead of them. And it excludes curative treatment. So you can't be receiving hospice services at the same time that you're still getting treatment. And this typically does not happen in the hospital, although it has, because sometimes they've been called in kind of late in there. But there's a case study that Catalyst for Payment Reform did with Dow Chemical, and they changed their benefit design so that some treatment could still be happening with hospice. And so that's an interesting case study to look at. Let me go on to the next page, which directs you then also to Catalyst for Payment Reform has what are called serious illness care strategies. And the link is in there. It's again in the employer guide, but it is a toolkit for employers, for purchasers. If you want to check that out, it explains the value of palliative care, how it can improve the quality of life for employees, not just with cancer, but other serious illnesses, and also reduce healthcare costs for the patient and also for the employer. And they've created an RFI. They've got model health plan contract language. They've got checklists. So it's a really good resource. They did it several years ago, but it's still very relevant. So I think that is my last slide. It is. So we have plenty of time for questions. That was a lot of my talking. So I guess we could take the slides down and pull everybody up. Would that be okay, Diana?
Yep, that would be just
I'm
great.
gonna grab a swig of my drink here.
Okay.
Let me turn it to you, Marianne.
Well, thank you so much for such
Chris?
a great detailed discussion. This guide is just phenomenal, the amount of information there.
A lot, and it's so hard, to kind of it can be overwhelming. But again, go back to there's 7
Mhm.
portals, if you will, right? And if you say,
Right.
"Look, I'm going to just start with screening," or I really got to look at paying for care. You
Right, which is really where the value is of having it sort of sorted out in the
mm,
different sections, because each one has none is a singular event. They're all connected as part of a whole. But it's nice the way that you divided it up into the different areas. And actually, when I think about it, when you start off, for example, the prevention and screening as the first 2 chapters or sections, um, that's just basically a focus that we've been trying to get a lot of our employers to focus on, because it's to get at early detection, which is
yeah.
she said is absolutely critical. But what I like today is where you went into the palliative care versus hospice care, and I actually didn't know the difference between the two.
Okay.
I
Well,
knew one
check
was
it out and you'll get all the
yeah.
specifics there.
So I
So,
mean, I'm learning as we go along.
yeah.
Um, I haven't had too much interaction in family wise is with cancer, so this is very interesting to see.
Yeah. Well, that's good news. I'm glad to
Yeah,
hear.
that's good news. So, how about questions from some of those who are participating? I don't want to hog the discussion because, again, I know you're.
Actually, before we go to that, Marion, what I meant to say, I don't think I said it, is when we had the in-person event, you talked about the report that you had on mitigating the
Oh,
impact of
yes,
cancer care.
we
So
did.
I haven't had a minute to get it into the microsite yet, but we reviewed it and I talked to Cheryl at MBGH, and we're going to make sure we get that in. So I don't know if you want to
Okay,
talk
I
about
don't know
that
if
for a
you all can
second.
see this or not, but this is it. It is on our website, I believe, mitigating the impact of delayed cancer care. And so the study that we did was with 2 of our employers to ask them to collect their data on the utilization data on mammograms and colonoscopies, or the Cologuard, um, cervical paps, smears, HPV vaccinations, lung cancer, and so on, for the different imaging tests for lung cancer, for example. And that alone was probably one of the most valuable, I guess not lessons, but the tools that we offer to our employers, just to take a look at what you've got. Because if you have, and you mentioned it, very low rates on
Mhm.
numbers of mammograms for age appropriate women, and numbers of lung screenings, for example, which is an expensive test to have done. You have to get, it has to be done at an imaging center. Um, it's interesting how many of our employers that we talk to about the screening have not ever asked for that utilization data.
Right,
So if they
right.
did it, when the 2 that participated did ask for the data, it came it was sent to them, to me as well, to look at it in just gobbledygook numbers of. We said, we just want to know the percentages. Just tell us what it was for 2022 and
Yeah,
20.
that came up, Marianne, in our discussions too, that oftentimes the employer will get like a gaps in care
Yeah,
report. And a
yeah.
lot of the time it's screenings, but it didn't say it didn't break it down by is that mammograms versus colorectal versus, and it also, what we
Exactly.
talked about was, okay, so is it a particular age group? Is it at a
Mhm.
particular work site? Is it a particular provider, primary care provider who's not pushing it? So
Yeah,
there's a lot of information if you really have low screening rates to,
right.
keep probing to see where the problem is.
Mhm.
Another thing that came up was give people time off from work to
Good
go get these
point.
screening tests, go get their,
Right.
their primary annual, primary visit.
Yeah.
Bring it to the work site. Bring a
Mhm.
mobile mammogram. Our folks at Rosen Hotels and Resorts bring a mobile dermatology unit because there's such a shortage of dermatologists and a long wait.
Oh,
So,
good.
so there's a lot
Yeah.
of strategies that,
Mhm.
to try to to get at it.
And I think
Chris,
the
I
employees
think
appreciate.
Chris had a comment. Chris, would you like to chime in?
Yes, I would, please. Thank you. One thing that Mary
Oh, I
Ann
couldn't see
and
your hand over your logo. I see it now.
okay,
I see it now.
so one thing that Mary Ann, Karen, and I all have in common is all of our coalitions are members of the National Alliance of Healthcare Purchaser Coalitions. And just coincidentally, all three of us are on the board of governors for the National Alliance. The National Alliance has been undergoing is focusing on high cost claims over the last several years.
Mhm.
And it's not shocking that for most employers, cancer is the highest cost claim that they'll have. And there's some real missed opportunities to better manage them. And this isn't available today, but I know that heads up, stay tuned kind of thing. A shout out for the National Alliance and for its coalitions that are members is they are looking at building a data warehouse to analyze claims, high cost claims. But more important, what the message we hear is we know the what, it's the how. How do you manage a high cost claim? And of course, we provided some of that here today, but that's still for most employers, especially for a benefits professional, they don't have the time to do this. It's not their full-time job. They hired a point solution. Sometimes those point solutions don't coordinate with one another. Long story short, there's the National Alliance is looking at developing not only the data capabilities and the analysis to support that, but the management capabilities that employer who are members of National Alliance coalitions will be able to take advantage of. It's not here yet, but I would think perhaps by this time next year, it will be. But in
Yeah,
the
Chris,
meantime,
I'm
this is a
glad.
great
Yeah,
guide.
I'm glad you mentioned it because when, it was presented to us a few times, so by now I have a little bit better idea of what it's going to look like, especially for the high cost claims solution. They're
The
talking
how.
they're talking with a bunch of solution providers who may come together, who approach high cost claims management in different ways. So some are about fraud, waste, and abuse. So that's one issue. Some are about, directing, site of care strategies. Some are looking specifically at,
Clinical
the
management.
drug cost, right? And looking at what's going on there. So they're all, kind of looking at it, because there's that's why we have the 7 sections here. There are so many points in the cancer patient journey that an employer could enter in to try to drive more value out of their plan and meet the needs of their cancer patients. There's so much that can be done. But Chris, you're 100% right. I know that your time is so stretched and it's so hard to be able to move the needle anyway because you're just, one. But I think the value of the coalitions is, maybe you all do pick something now because we're a year out maybe from some solutions. But if everybody's moving in the same direction on biomarker testing, in a coalition, you might be able to get the health plans, to straighten it out, or, going back to screening, getting the data. Everybody, everyone who's working with Cigna, everybody's working with United Healthcare. Let's get this figured out because without that kind of data, and that will not be probably, Chris, in that data warehouse because so much of that screening is, zero claim, right?
Yeah.
So things to think through that we can do in the interim, but I am looking forward to seeing what that solution looks like because if it comes at high cost claims and oncology in particular, from, all these different areas that need help, then it's going to be quite a magnificent tool.
Yeah.
So, does anyone who's participating have any other questions or maybe some examples of some of the work that you're doing, not only just from the prevention and screening side, but on into what Karen was talking about today and navigating care management? That seems to be, wow, that seems to be such a powerful resource to offer the patients to have the navigation. It seems like they need it most when they've been diagnosed with the cancer. Anyway, is anyone in the group using a navigator for that type of helping cancer patients and for other types besides just cancer patients? The silent ones here.
Everyone's free to unmute and speak if you have a comment.
Yeah.
Come on camera. Say hi.
Yeah. That seems to be just a really powerful tool to offer to patients with cancer.
Well, I'd be happy for, the three coalitions, or maybe I won't volunteer MEGH, but I'm sure they would also. Maybe there's some things that we can do at a national level with some of the carriers, in that screening and getting, what does a report look like that would be meaningful to be able to identify where you can have an intervention. Because again, it's not all the cancers. But it's 30% of them we can get at.
Right. So what we'll do is send to everybody who's participating the copy of our the cancer prevention, cancer screening test that we did, because it's real simple looking at a chart of just the utilization on the different types of cancer that tells the whole story right there. And then we also collected the data on how many cancer claims they had per year, and in the three key years that we're looking at, and then the cost of those cancer claims. That's
yeah, it's great.
I think they get that anyway, that data, but just knowing what you can do to increase the mammograms, increase the colonoscopy. I always think of David Hines. He's with the Memphis or Tennessee school system.
It's the Metro Nashville School District.
Nashville School District.
Yep.
He's spoken about how he brings in he has a mammogram Saturday.
That's right. That's right.
Instead of mammogram, and he has the mobile mammogram truck with.
I think he just retired.
Oh no! Don't tell
Big
me
shoes to fill at Metro Nashville School District, because David, we've brought him in to speak about all different kinds of innovation, and he's done a lot of great work in oncology. He's done great stuff in women's health and maternal and child health. I mean, he gets ex-carrier to do what he wants, and so if we can get some successes like that, you can ride the coattails, right?
Right. He needs to come out and speak on it more often, even though he's retired.
If he retires like everybody else retires, we'll see him soon.
Yeah.
Hopefully he just announced it, and it's not taking effect. It was supposed to speak at one of our webinars in another few months.
Oh, okay. I thought it was at the end of the school years. So maybe his contract goes to, through the summer.
And I imagine that some of our participants today have some interesting stories to share as well on, if not a mammogram on a Saturday at the office, then there are other ways.
We'd love to hear anything that you're doing that in any of those, content areas that you've tried, had success with. We are collecting those insights and those stories. So
in collecting those stories, Karen, are you thinking about releasing sort of the compendium of employer stories on what they're doing on the cancer care? That might be interesting to add.
We certainly could. I mean, they're all in each of those microsite content areas, but maybe it would be interesting to get a compendium on there. Well, we need some Texas stories. So we've got
Yeah.
so I would say reach out to Chris, reach out to Mary Ann. They know how to find me. And we'll spot.
Yeah, just you mentioned keeping this evergreen. Last week in Dallas, the National Alliance met, and I was subject to a wonderful wine tasting event. But at that event, I learned that there is a new technology for breast cancer screening that will make mammograms ancient history.
Oh, well, that's good. I
Uh,
can't wait to hear about that.
yeah, and it's think a year or two out. So there's a lot on the horizon, and again, we hope to keep this evergreen and with employers at the lead.
That would be wonderful to have something like that. I did see one demo for one. I can't remember what it was called. This was several years ago. It was almost like a sonogram that you actually used, a little machine that you use to detect the cancer cells in or whatever whatever the mammogram was looking at. It's just you kind of do it yourself with this little machine,
Okay.
a wand of some sort. I'll have to go back and look at my notes to see what it was. But there are easier ways now. If someone finally comes up with better ways for colonoscopies, I guess the Cologuard is a good substitute for that. So none of these tests are all that great.
Yeah.
But they're important.
I know. It's like if you want to learn more about different ways to encourage getting colorectal cancer screening, Ken Aldridge from Rosen Hotels and Resorts was like one thing after another. You're not going to do a colonoscopy. Let's do the FIT. If you're not going to do, FIT, he was looking at like the multi-cancer early, all of these different things to try because he had such high rates of colorectal cancers being found, really, really high. So there's more of his story in there too.
Yeah.
All
Well,
right.
we're coming up to closing time, so I just want to remind everybody that we do have our next webinar. The best and the last is going to be we said that was July.
July 24th, I believe.
And that's going to be survivorship. You return to work and paying for care.
That's going to be a really big one, the paying for
care.
That's
I'll have to get ready.
July 24th. It will be from 12 to 1:30 for everybody. So mark your calendars for that. We definitely will send you reminders. But be thinking about your own experiences in paying for care, which is what we'll be talking about, and survivorship and return to work. Those are major, major issues that I know employers are dealing with, and we kind of save that, kind of put it off to the side. But I think that's equally important to for the return to work and paying for as the front end, which is the screening and prevention.
Right.
Karen, thank you so very much for your time today. You're always you're full of so much valuable information and so well presented in just such an orderly way.
Well, thank you, Mary Ann.
Really appreciate this.
All right.
Okay. Well, thank you.
Enjoy the rest of your day.
On this.
All right. Take care, everybody. We'll see you in a month plus. Everybody who's going on vacation, have a safe and fun time, and we'll see you when you get back.
Travels.